Hello and welcome back to the channel. Over the next few sessions we'll be discussing a very important topic, and that is breast cancer reconstruction, particularly after a mastectomy. My name is Dalia Masood and I'm a plastic and reconstructive surgeon. Breast cancer is the most common cancer in the UK, with a lifetime risk of around 1 in 7 patients. This is incredibly high and becomes higher when you have been diagnosed with the BRCA gene or if there is a genetic link to your breast cancer, and can be up to 85% lifetime risk. Approximately 56,000 women a year are diagnosed with breast cancer, and between 30 to 40% of these patients require total breast removal. This can obviously be devastating for patients. However, there are options available in terms of reconstruction of the breast. Now, the reconstructions do not replace the breast, but they will provide you with a breast that will help with many functional and psychological aspects associated with breast cancer and the mastectomy. Although most of these patients are above 60, there are an increasing number of patients under the age of 40 that are developing breast cancer and require mastectomy. Of the patients that need a mastectomy, about a third will go on to have a reconstruction either in the immediate setting. That means having the reconstruction at the same time as the mastectomy, or they may choose to have the reconstruction at a later date, which means they would have the mastectomy first, as well as the chemo and radiotherapy, recover from all of that, and then come back to have their reconstruction at the later date. Research has found psychologically patients that have a delayed reconstruction actually do better. So today we're going to be opening up the discussion and exploring what's available in terms of reconstruction. We'll talk about the pros and cons of each procedure in the upcoming sessions, so please subscribe so you can be fully informed. We'll also talk about the common risks and the trade-offs, and how each type of surgery can affect you both in the long term and in the short term. So just to start you off today, we're going to be talking about the different types of free tissue transfer that's available to help reconstruct the breast. Now, what's free tissue transfer? Free tissue transfer is when we take one part of the body. Now, in terms of breast reconstruction, this will be one part of the body that has fat and skin. This is detached from that part of the body, shaped into a breast. A blood supply is taken with that block of fat, and it's reattached to the defect of the breast where the old breast was. And we use a technique called microsurgery where we reattach that tissue. So because it's becoming free from your body and reattached, that's why we describe it as free tissue transfer. So when it comes to breast reconstruction, what are the free tissue transfer options available? Today we're going to be focusing on the scars that you get from the different types of free tissue transfer. So which part of the body do we decide we take the tissue from? This depends on a number of factors. Your own body habitus, whether we're doing one side or two sides, and how active you are. If we're doing a one side, we generally call it a unilateral. So you may hear us talk about unilateral reconstruction. If we do two sides, we will describe it as a bilateral. So that's two-sided. That's terminology that we may use amongst ourselves. So what are the different areas that we can take tissue from, or skin and fat from? The most common area is the tummy area. This is the area that you can squeeze or grab when you're sitting or bending down. We take the tissue from the belly button down to the knuckle, and that procedure or area is called the DIEP. The next most common area that we take the fat from is just below the groin line on the inside of the thigh, extending into the buttock region. This fat is not as prominent as the belly fat, and depending on your body shape and size, we may have to use one side to reconstruct one breast or two sides to reconstruct the same breast. And this is known as a PAP flap. The other areas that we can use is your lower back or the lumbar flap region. This is the least common area where we take the fat from when it comes to reconstruction, but it's just because most people have the tummy fat or the thigh fat available to us. So we'll talk about the different types of scars with the different types of reconstruction. Whether you're having an immediate reconstruction or a delayed reconstruction, this will determine the scar pattern on your breast. So we're going to be focusing on the scars on your breast. So if you have an immediate reconstruction, so that is the reconstruction at the same time as your mastectomy, you will have a round scar where your old nipple was. This is particularly true if you are having your nipples removed, and this is the most common form of scar pattern if you are having an immediate reconstruction with your own tissue. A very small percentage of people may choose to preserve their nipple, so they would like to keep their nipple. If this is the case and you are having an immediate reconstruction, your scar will be at the base of the breast with a small skin paddle that will be the new tissue that we've added to make in the breast. So immediate scar pattern is round if we take the nipple, and if we keep the nipple, it'll be underneath the breast. Now, if you are having a delayed reconstruction, i.e. you have your mastectomy and you come back 1 or 2 years later to have your reconstruction, the scar will run across the breast. This is because we are using the mastectomy scar, lifting the skin up and placing the new tissue underneath this skin, leaving you with an eye-shaped scar with the upper part of the eye on the mastectomy across the chest and the lower part of the eye just hidden underneath the breast. So that's the breast, regardless of the different types of areas we take the fat from. Now, what will it look like where we take the fat from? If you are having a DIEP reconstruction, your scar will essentially run from hip to hip, and you will have another scar around the belly button. We try to keep the hip to hip scar as low as possible, but this does depend on a couple of factors. Number one, how much excess skin and fat you have. If you have lots of skin and fat in the lower part of the body, I can try and keep it as low as possible. If you are quite slim and things are tight, the scar can lift automatically, or I may have to lift the scar slightly higher than the knicker line, and that's to make sure that the scar isn't too tight. The other things that can determine how high or low the scar is how high or low your blood vessels are. Now, if your blood vessels sit high, I may have to lift the scar higher to catch those blood vessels. But in all these situations, they do remain within the knicker line as much as possible. With the DIEP scar, you will likely have numbness along the scar, which can be permanent, but in some cases it can be temporary. And that will feel a little bit weird when you pull your trousers along the scar and the skin feels slightly different. If you have a PAP reconstruction, the scar sits about, give or take, an inch below the groin on the inside where you wear your knickers, and it will extend or creep just behind the buttock line. Now, this is a great scar and can be hidden. It's nicely tucked away. But one of the things about this type of scar, because it's so tucked away, if you do have a problem, it can be difficult to detect. And this is particularly if you have an infection, it can be difficult to see. And because it is in the groin region where it's hot and moist and it's close to areas that can be easily contaminated, it is at a higher risk of infection. So we have to be extra vigilant with the groin when it comes to a PAP flap to prevent infections, because of the nature of the location, it is more susceptible to infection. So that's something that you have to be aware of. With the PAP scar, you will have numbness on the inside of the thigh and sometimes running in the buttock region. So if you're sitting down, you may notice it feels slightly different. The final procedure that we do at our unit is the lumbar reconstruction. Now, this is where we take the fat, which is at the lower back, that you can grab if you have it, just beyond the love handles. This reconstruction, we use one side to reconstruct one breast, and you will have a scar at the base of your back. This scar, again, generally hidden. You do have numbness along the back with this procedure, and a certain number of people do develop back pain after this procedure. Now, because it's in the lower back, one of the things that we need to be aware of is that there's a high risk of stretching in this area. So this kind of scar is more likely to stretch. So we may choose to do one side, and what we do is leave the other side in case we need it as a backup. And once the breast has settled down and there are no issues with the remaining breast, we can either symmetrize you by removing that extra fat, or we can choose to just leave things alone. From personal experience, some patients do choose to leave things alone, as the difference isn't massively bothersome, and it's there if we do need to have a backup. So today we've just touched on the different types of free tissue transfer to reconstruct the breast, and the different scars that you will get on the breast, and also where we take the tissue from. Now, this is a huge topic, so we will discuss in bite-sized manner different things each week. If you'd like me to discuss a particular aspect of breast reconstruction, please let us know, and I'm more than happy to go through this in one of our sessions. I'll also be inviting different breast cancer reconstruction surgeons from the UK and also internationally to discuss their experience for breast cancer reconstruction. So please subscribe, stay tuned. If you found this topic helpful, if you have a loved one that's going through this journey, share this, and hopefully I'll see you in the next video.